Chairman, we're ready to begin.
Thank you, Denisha. Would you please begin this morning by calling the roll of board members, please?
Yes, Chairman. I'll begin with Norman Boyd,
Here.
Cynthia Rucker,
Here.
Roger Folsom,
Here.
David Cruz,
Here.
Anthony Williamson,
Here.
Shane Mobley,
Here.
Robert Coles,
Here.
Tommy Hopkins, Kathleen Ruth.
Here.
Chairman, that concludes my roll call.
Thank you, Denisha. And we do have a quorum of board members, so therefore we can conduct business.
This is Hopkins. I'm here also.
Well, thank you. Thank you, Dr. Hopkins. That means we have 100% attendance of board members today, and thank you for that and taking the time. As we will call the meeting to order, and as a review of the things that we will be asked to address today, we will be covering two different items that we'll be asked to vote on for final approval after the presentations, and one item of initial approval to consider. In addition to that, and the primary reason for the meeting today is the State Health Benefit Plan. And we will all received a presentation of that in writing, and we'll go into that after we have addressed the other items that we need to vote on. Next on the agenda this morning will be the minutes of two previous meetings. One in the June 24th meeting, the minutes. I'll call on Dr. Rucker, our secretary, if she's had a chance to review those minutes and would recommend that they be approved.
Good morning, Chairman Board. I have reviewed the minutes from June 24th and July the 11th. I do find them to be in order, and I do recommend they be approved as stated.
Okay, we're asked to take two separate votes. So the June 24 meeting minutes of the June 24 meeting, it has been recommended they be approved. Is there a second?
Folsom, second.
Roger Folsom has seconded that. All in favor say aye.
Aye.
Aye. Opposed? Abstaining? Hearing none, they are approved. And Dr. Rucker has previously stated that she's reviewed the July 11 minutes, and I believe I'm right on this, that you also recommend approval of that. Is that true?
That's true. Yes, sir.
Is there a second to that?
Second, Dr. Coles.
Dr. Coles has seconded that motion. All in favor say aye.
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 Opposed? Abstaining? Hearing none, it is approved. Two minutes are approved. Thank you very much, Dr. Rucker. Next on the agenda, we'll move to the commissioner's report. So Commissioner Carlson, would you open your report, please?
Yes, sir. Thank you, Mr. Chairman, members of the board, all those watching virtually. I hope everyone enjoyed a wonderful summer and is off to a great back to school season. I know it's wide open at the Carlson household. Also want to acknowledge, before I go too much further, to acknowledge our friends and neighbors in South Georgia, specifically Southeast Georgia, who have endured a rough couple of days with the storms. Thank you to all the healthcare providers that have navigated that and still managed to deliver the services those communities are relying upon. And I also want to thank our own team, largely our HFRD team, for standing post during all this, and specifically Anthony Moss on the HFRD team, who is our designee at GEMA and the State Operations Center in times like these. So I know a lot of people involved in that, and you're never quite out of the woods until you're out of the woods. So everyone remain vigilant, and I hope this wraps up soon. But while we continue to stay busy here at DCH, the board, the members, you have been especially busy with an additional called meeting in late June alongside our traditional pair of meetings here in August. The board would have held 5 meetings in 3 months, and we're very appreciative of your time, commitment, and service. And make no mistake, we still have some full agendas to come in September and October and beyond, and then the legislative session will be upon us. So thank you. Please know that your commitment isn't lost on us. And as always, I do want to remind you to feel free to reach out to us, as some of you have recently, when it pertains to how our staff can help walk through any agenda items and provide a deeper dive, an information session for anything. This is oftentimes very technical, a lot of large dollar figures. So tell us, please, how the staff can better inform you from when you've gotten the packet in hand and still have questions leading up to the board meetings. And in some of those same recent conversations with board meetings, I was asked about a recent exchange between board members and several dynamics surrounding pharmacy issues here in Georgia and nationwide, specifically around pharmacy benefit managers, both independent and chain pharmacists, and those relationships. Traditionally, though, specific to the minutes, I was asked about the minutes as they pertain to that dialogue between the board members from the July 11th meeting. It was a good dialogue and one that we always welcome. Traditionally, the DCH minutes do not reflect the dialogue between board members. Usually our minutes reflect the actual board actions taken, and then we rely upon Denisha and our IT team that do a great job of posting the full board meeting in its entirety within 24 hours. And so we're reliant on that prompt posting and archiving of the full board members for the public, to include board members to not only consume that information, but also distribute it to anyone that they see fit. So I did want to answer some questions as it relates to the exchange and how it pertains to the minutes. But on a related note to the subject matter content that was discussed on July 11th as it relates to pharmacy issues as a whole, that does bring us to one of the updates I want to provide. We often get asked about the progress and status of some of our larger long-term projects. One of those is the PBM for the State Health Benefit Plan. As of Monday, August 5th, this past Monday, SHPP posted a request for information, an RFI, for the procurement of the SHPP Pharmacy Benefit Manager. This is a market scan of sorts for both vendors and stakeholders alike, a customary traditional first step in any large procurement. So that's posted on our website for everyone's awareness as we prepare ourselves for the preparation of a formal RFP later in the year. But giving long-standing established timelines and deadlines that we need to meet for contractual responsibilities, this RFI will only, it's going to be open until August 14th, which is next Wednesday. So we do want to make sure the public's aware of this, as I know there's always been a lot of interest. So August 14th, that will give our team time to look at these responses, assimilate that information, and factor it into further deliberations here at the department. And then on a related note, another project that we're asked about, and I just don't want to remain silent on these large issues of importance, the CMO procurement. The evaluations continue to be underway alongside our partners at DOAS. Very healthy debates on a very regular basis, late nights and early mornings of substantive dialogue on these issues of importance. We're very encouraged about the progress that's being made. Appreciate DOAS's guidance as we keep these procurements in a responsible place for both procurement and legal purposes as we position the state in the best position possible to have a good, clean procurement, responsible procurement that really represents a lot of thought and deliberation on these matters. So full steam ahead with progress being made, and we'll continue to keep you apprised of the status of these efforts, and not to mention any large long-term efforts here at the department moving forward. But as always, I have to share that we do have a responsibility to be transparent to the public and share the progress. And when things are posted and dates and deadlines that you need to be mindful of, these things literally impact millions of Georgians. But the department, staff, and board alike, we're constantly mindful of how important it is to foster a fair procurement environment that allows vendors and stakeholders a good voice and a good place to present their thoughts and proposals. And the department has a responsibility to be a good, objective partner in that process, not to mention our numerous legal responsibilities in that process. So things are moving well, and we'll always try to conduct our business in an efficient manner, but more importantly, a responsible and fair manner on all these major issues. So that being said, Mr. Chairman, I'll hand it back to you for the remainder of the agenda.
Thank you, Commissioner. Are there questions or comments from the board for the commissioner, please? Hearing none, thank you very much for your report, and we'll move into the first item on the agenda that we're going to be asked to consider for final adoption, medical assistance plans, and Brian Lipton, Director of Strategic Finance, will make that presentation.
Thank you, Mr. Chairman, and good morning to you, members of the board, and Commissioner Carlson. Pending CMS approval, a new state-directed payment plan program will be implemented effective retroactively to July 1st, 2023 for the Georgia Families 360 program only. Georgia Families 360 is Georgia's managed care program for children, youth, and young adults in foster care, children and young youth receiving adoption assistance, and select youth involved in the juvenile justice system. The Care Management Organization contract for Georgia Families 360 annually funded a value-based payment program through a 5% withhold arrangement that focused on value rather than volume to accomplish certain initiatives measured in terms of outcomes, quality of care, and other factors. CMS notified the department that the existing withhold arrangement is no longer permissible, but that the state fiscal year 2024 capitation rates would also require an adjustment in the absence of that withhold. Restructuring the arrangement as a DPP was one of the recommended options from CMS that would allow the department to use the existing rates through the end of fiscal year 2024. The Quality Initiatives and Care for Kids, QUIC DPP, will provide funding to specific providers serving Georgia Family 360 members to incentivize delivery of high-quality care. The DPP will transition Georgia Families 360 from a value-based purchasing program to a DPP by utilizing half of the 5% withhold arrangement to a capitation rate increase as directed in the DPP preprint. Accordingly, the existing withhold arrangement will be reduced by 2.5%. At the direction of CMS, the withhold arrangement will be removed from Georgia Families 360 starting in SFY 25. And the QUIC DPP payment is intended only for state fiscal year 2024, and there are no plans to renew in future years. There is no projected cost as the DPP amounts will be offset by the reduction to the withhold arrangement. An opportunity for public comment was held on June 26th at 11 a.m. via Zoom. Written comments were due on or before July 3rd, 2024. No oral or written comments were received. And with that, Mr. Chairman, I respectfully ask for the board's favorable consideration of this item for final adoption. I'm glad to take any questions.
Questions, comments from the board, please, for Brian? Hearing none, we're being asked to consider for final adoption. Is there a motion to approve for final adoption?
So moved, Hopkins.
Dr. Hopkins has made the motion for final adoption approval. Is there a second?
Second, Kathleen Ruth.
Dr. Ruth has seconded that motion. All in favor, say aye.
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 Opposed? Abstaining? Hearing none, it is approved. Brian, thank you very much. And you may move to your next item.
Thank you, Mr. Chairman. Pending CMS approval, the department proposes a revision to the allocation methodology for the Disproportionate Share Hospital DSH program effective July 1st, 2024. Eligible hospitals in Pool 2 that are classified as a rural referral center by CMS and that are not eligible to participate in the Georgia Aid or Georgia Strong state-directed payment programs will receive an allocation no less than 25% of their DSH limit. Rural referral centers are high-volume acute care rural hospitals that treat a large number of complicated cases. There is no change to the current methodology for eligible Pool 2 hospitals that are not classified as rural referral centers. Due to the DSH payments for RRCs, rural referral centers, being calculated differently from the remainder of Pool 2 hospitals, there will be two different allocation methodologies. Methodology A will begin by calculating 25% minimum payment, and that will apply to the rural referral centers. And methodology B will apply to all other eligible DSH Pool 2 hospitals. Additionally, the Pool 1 definition will be updated to include eligible critical access hospitals and rural hospitals with less than 100 beds. This removes eligibility for state-owned and operated acute care hospitals because presently there are no hospitals in the state that meet this definition. There is no change to the amount of funds available for DSH payments, and there are no projected cost impact. This proposal only changes the distribution of those funds. An opportunity for public comment was held on June 26, 2024 at 1 p.m. via Zoom. Written comments were due on or before July 3rd, 2024. No oral or written comments were received. And with that, Mr. Chairman, I respectfully ask for the board's favorable consideration of this item for final adoption. I'm happy to take any questions.
Questions, comments from the board, please, for Brian? Hearing none, is there a motion for approval for final adoption?
Motion for approval, David Cruz.
David Cruz has made the motion for final adoption. Is there a second?
Shane Mobley seconds.
Shane Mobley has seconded that motion. All in favor, say aye.
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 Aye. Opposed? Abstaining? Hearing none, it is approved. Brian, thank you very much.
Thank you.
Next item for consideration for initial adoption, Stuart Portman, Executive Director, Medical Assistance Plans, will make the presentation on medical assistance plan for hospital services.
Thank you, Chairman Boyd, members of the board, and Commissioner Carlson. This is about the extension of the hospital Medicaid financing program. And the hospital Medicaid financing program is used to assess one or more provider payments to hospitals in order to obtain federal financial participation for Medicaid. Per the enactment of the Hospital Medicaid Financial Program Act in 2013 and subsequent reauthorizations, the program was extended through 2025. Per the provisions of House Bill 991 this past legislative session, the Hospital Medicaid Financing Program was extended through June 30th, 2030. This allows DCH to continue to assess one or more provider payments on hospitals to obtain FFP. An opportunity for public comment will be August 14th at 11:30 a.m. via Zoom. And there is an opportunity for written comment through August 21st, 2024. The department seeks initial adoption to extend the program through June 30th, 2030. There are no changes to the program. It is only the date.
Thank you, Stuart. In our process, initial adoption means it, as you said, goes out for public comment, and then you'll come back to the board after you have assessed that. Is there a motion for approval for initial adoption?
Folsom, motion for approval.
Roger Folsom has made the motion for approval. Is there a second?
Hopkins second.
Dr. Hopkins has seconded that motion. All in favor, say aye.
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 Opposed? Abstaining? Hearing none, it is approved. Stuart, thank you very much.
Thank you.
As in the past, and we have thanked the presenters today for providing the materials to the board in advance, so we had an opportunity to review those before today's meeting, and we appreciate your presentation. It's a process, and we know there's a lot of background work that goes into all of these things. So we do appreciate that and appreciate being provided the information in advance. Next item and final item on our agenda is a very important one, is our annual approval of the state health benefit plan. And just as a reminder, or the board's responsibility in this process is really two things, is to approve the design of or structure of the state health benefit plan and the rates. Those are the two issues, or the two main things that we as a board will be voting on at the conclusion of Lewis's presentation. And we've been provided a copy in advance again of your presentation. We appreciate that, and we'd like you to add the detail, and I'm sure there will be questions either as you go through it or at the conclusion. Please go ahead, Lewis.
Thank you. Good morning, Chairman, board, members of the board, Commissioner Carson. Lewis Amos, Executive Director of the State Health Benefit Plan. As the chairman indicated, I'm going to provide a presentation as it relates to the 2025 benefit year plan recommendations, and we will go ahead and start with that.
Would you raise the volume a little bit? It's just
Okay.
might help.
Is that a little better?
Yeah.
Okay, all right. I'll speak a little closer into the mic. So we could pull up the presentation. Okay, we could go to the next slide. As always, our purpose is shaping the future of a healthy Georgia by improving access and assuring quality to strengthen the communities we serve. Next slide. The agenda this morning, we're going to go through the accomplishments for the 2024 benefit plan year, talk a little bit about plan overview and historical trends, and then go through the recommendations for the 2025 benefit plan year, which will include plan options, plan design, member premiums, and then the open enrollment for the 2025 plan year. Next slide. Accomplishments during the 2024 year. We completed a Medicare Advantage procurement for vendors through our invitation for proposals. You'll hear this word IFP process, which resulted in Anthem and United Healthcare being offered to plans, manage the Medicare Advantage plans for the 2025 year. We increased focus on mental health services. As we all know, mental health services is probably one of the most critical areas throughout the state that we are really seeing an uptick in terms of utilization. We held our first mental health summit meeting for employer groups, and this was open to all, both state agencies and school employees, benefit representatives, to really talk about mental health, talk about the services that are available. We established mental health programs for areas in the state where there's limited provider access through telehealth and virtual services. We are happy to say we are in the process of installing an on-med health station, which is underway through our partnership with ShareCare. So for members of the board, the next time you're here in the towers, we invite you to come and see that station. It is a unique concept because it merges kind of the virtual telehealth level of service also with technology. So it has some uniqueness, and these services will be free to state health benefit employees where they have an opportunity to do blood pressure, various different, allergies and things of that nature. So it is a unique opportunity that we're looking at, and obviously, based on the response, we'll look to potentially expand that in other areas of the state. But it is it's a quite a impressive station that we really are looking forward to seeing how it helps our state health benefit plan members. We implemented the undual diabetes management program. As we all know, diabetes is probably one of our leading costs in terms of medical costs. So this program is specifically, we're working with both United Healthcare and Anthem, and it's working to target diabetes education, diabetes management in some of the regions throughout the state. So we'll continue to put forth programs that will focus on diabetes, since it is probably one of our most critical areas in terms of chronic diseases. Next slide. Next slide. On historical trends, just to kind of give you a little bit about the plan overview. The self-funded claims paid increases, that's for the HRA plans, the HMO plans, have increased from about 12% from 22 to 23. A significant boost to that growing cost have been the anti-obesity medication and utilization. So those GLP-1s, we are one of few states in the country that are actually covering it. And as you can imagine, there is a cost associated with it. Cost drivers, when you talk about cost drivers, as you know, general inflation in terms of healthcare. Healthcare is continuing to go and be one of the #1 leading costs in terms of the country, in terms of economics and the impact on families. We continue to have prevalence of chronic conditions, diabetes, hypertension, obesity. Yeah, as we've all said, we know we live in the stroke belt here in the South, and we're probably leading the country as it relates to diabetes, obesity, and hypertension. And as you can imagine, with those conditions, there are other more serious conditions that often are associated with that. So our efforts is to really continue to try to focus on educating, awareness, and also trying to have the consumer take a more active role in their own healthcare decision-making process. The increase in terms of specialty medications, as we all know, the specialty medications, they're coming out with new drugs. These drugs are very expensive. We're living longer, but there is a cost associated with. I mentioned about the GLP-1s, the anti-obesity medications. The state health benefit plan started in July of 22 to cover those medications. And as you can see from the 2023 to 2024 June, in the same time period, we had a $10 million increase. It went up to about $20 million, and the driver of that is probably the drug Wegovy. And one of the things we're going to see is that there will be an increase in utilization as you see these drugs are being recommended for other medical conditions. You got the whole supply and chain demand scenario. And then these are injections. So we can anticipate when you have a oral medication available that the utilization will probably increase similar. So, we're continuing to monitor it, but, obviously the jury's still out in terms of return on investment for these medications, but there have been proven thought processes that it helps with other medical conditions. So we'll continue to see how that goes. Next slide. The recommendations for the 2025 benefit plan year, plan options, the medical vendors will remain the same. United Healthcare will offer an HMO, a high deductible health plan, and the Medicare Advantage plan. Anthem Blue Cross Blue Shield will offer the HMO plan, the HRA plan, Medicare Advantage. Kaiser will continue to be the regional HMO. The pharmacy vendor will continue to be CVS Caremark, and the wellness vendor will remain the same in Sharecare. Next slide. Plan designs. Our recommendation is for no changes to the plan design. So the current plan designs that are in place now for the 2024 year will be recommended to be in place for the 2025 benefit plan year. So no increases on co-pays, no increases on deductibles, or anything of that nature. Next slide. Member rates. I want to spend a little time and talk here about member rates and kind of give a historical perspective because I think it's important that we understand rates and how things have transpired. The slide that I'm providing you basically shows over a 10-year period, and you can see that the average increase, annual increase over a 10-year period is about 1.4%. And the significance of that is that it is actually you're below in terms of what the claim costs are. There were some years where we had zero increases. We had a 5% for the 2024 year. So we are recommending an increase this year, and you will go to the next slide. I'll get more into what the recommendations are. And this recommendation will be for the commercial non-Medicare Advantage plans. So if you go to the next slide, please. So the average, based on a weighted member increase, and let me kind of preference here that the actual increase will vary based on tier and plan options. But the state's subsidy is based on the bronze plan, which is our least expensive plan. But with that weighted average for the self-funded plans, we're looking at an increase of about $5.83 per member per month for an individual employee only, and about $22.74 for employee and family. And I really want to kind of focus down in on giving some examples in terms of some actual rate increases, how it would impact employees from a dollar perspective, because it's always, really clear. The Anthem Bronze Plan, there's a $4.98 employee only increase and a $20.97 employee and family. The Anthem Silver, it's a $5.98 employee only and $23.77 for employee and family. The Anthem HMO, there's a $9 for employee only and a $32.24 for employee and family. Kaiser, we'll see a decrease in the Kaiser rates, and there are a couple of factors that contributed to that. Kaiser came in with a very extremely low increases in terms of their premiums. Kaiser's a fully insured plan, unlike the other plans that we mentioned, they are self-funded. And then on the contribution level, we basically, the Kaiser plan from a rate perspective is probably one of the second least expensive plans. So we made some adjustments. But for those who are in Kaiser, there's a $12.01 decrease in employee only and a $33.70 for employee and family. In addition to that, Kaiser is increasing their service area. We're expanding. They have a facility in Athens, and the Oconee, Clark, Oglethorpe, and Madison County are now in the Kaiser service area. We can go to the next slide. Medicare Advantage. As we know, this is to our Medicare Advantage, our retirees, there are two important things we already know for you. One is the pension and one is the insurance. So, we're committed and trying to basically make sure we provide them with the best plan that's offered. But based on a historical perspective, UHC was the lower cost plan for over the past 10 years. Members paid the cost difference if they wanted to buy up to the more expensive Aetna plans, Anthem plans, and members paid $20 for the lowest standard plan prior to it becoming zero in 2021. Next slide. As I indicated, we completed the invitation for proposal for the Medicare Advantage vendors. Anthem and United were selected as the vendors. From a state perspective, we're moving kind of to a level dollar subsidy where we're basically all vendors and all plans are being funded the same way. There will be an increase in premiums. The lowest cost standard plan will be Anthem, which will be $20, and it matched the rate that was in place in 2020. Members who want to basically go with United, either one of the two premium plans that are offered will have to pay the difference, the full cost in terms of buying up. We will have an active enrollment period for our Medicare Advantage folks. These are the retirees 65 and older, and we will talk about that and in terms of how that process is going to work. But more importantly, we want to make sure everybody understands that nobody will lose coverage as it relates of this active enrollment. But for the 2025 benefit plan year, the Medicare Advantage standard for UHC, those premiums will be $82.59. The Medicare Advantage premium plan with UHC is $218.39. The standard plan and Anthem will be $20, and then the premium plan will be $187. Next slide. As I indicated, in terms of the open enrollment period, it will actually begin October 16th through November 8th. As I stated, for the active employees and then the pre-65 retirees, basically they will have the same type of enrollment, more of a passive enrollment. We do ask you to go in and look at your information and make sure, verify everything is fine. But if you don't make any selections, you will automatically be rolled over to what you had in the 2024 benefit plan year. But for the retirees, the Medicare Advantage and retirees, that will be an active enrollment. The participants will be required to make a selection. And if they fail to make a selection, we will automatically put them in the lowest cost plan. I know this is a change. So to kind of help with this change, we have scheduled 6 meetings through a program we call Medicare Advantage University. Those meetings will begin on August 21st, so they will be throughout the state, and they are geared specifically for our Medicare Advantage population. So what this program was developed about a couple of years ago, what it does is help those who are aging into Medicare and then those who are already in Medicare. You know, Medicare is a very complex plan, but we're working to try to help to make sure that they understand how it works and how for them to maximize their choice. The other thing here is that we will have 15 retiree change option period meetings starting on October 2nd. So there will be 15 meetings specifically for the retirees that will be held throughout the state. There will be 12 active meetings for active employees. So we and these meetings, as you can see, will start significantly prior to the October 15th start of open enrollment. And then obviously we will be available. Members can enroll through the website and also via telephone. So there is an option. I know that it may be challenging for some of our seniors in terms of going on the web and going to try to enroll, but we do have the ability for them to opt in through the telephone. And I've already indicated about the in-person meetings. Next slide. And as I complete what our mission, as always, is to provide healthy access to affordable quality healthcare to Georgians through effective planning, purchasing, and oversight. And we are dedicated to a healthy Georgia. Chairman, board, and members of the body, I want to share there are 2 resolutions that we're asking for your approval. We want to remind you that one of the resolutions, we typically will have 3, but in the May 9th meeting, we adopted the employer contributions for the teachers plan and the public school employees plan when we increased that contribution. So the certified employees contribution changed as of July 1, and the non-cert employee contribution will change as of 1/1/25. The 2 resolutions that we have before you, one is for the state employee plans, the employee contribution, which is the same, which has been, and the other resolution is for the member premiums that I've previously presented to you. So I respectfully ask your approval of these resolutions, and will now entertain any questions that may come from the board.
Questions, comments from the board, please? For Lewis?
Yeah, hey, this is Shane Mobley. I have a question for Lewis. On the PBM using CVS Caremark, we are paying them to pay out pharmacy benefits.
Yes, sir.
Why can we not require CVS Caremark to pay independent pharmacies the exact same amount that they enrich themselves for the same drug? Some of these drugs are, they're paying themselves $40, $50 for a drug and they want to pay independent pharmacy $1 or $2 for a drug. That's a problem. Another thing, concentrating so much of this on these pharmacies, I can just tell you for our practice personally, we're having issues with people getting medications filled from just CVS themselves. Commissioner, we have CVS now telling us that if we send prescriptions over, that they can't get them the same day, that they're going to have to get them. They have to wait 24 hours before they can get medications filled. And that's an issue for not just state health benefit members, but for anyone else in the state that needs Paxlovid for COVID, any type of thing for the flu or anything like that, going to a pharmacy and going, yeah, I'm sorry, we're out, or I'm sorry, you got to come back the next day. When we have a tremendous amount of independent pharmacies out there that are willing to fill these drugs, but they can't get paid because CVS is just taking all the money. So why can we not require them to pay the same amount? I mean, it's kind of infuriating, really.
Yes, sir. Mr. Mobley, this is Russell Carlson. I can take that one. So I appreciate you passing along the feedback you get directly from the field. That's what we're all here for, and I value that. And obviously, we have a lot of conversations about the dynamics, as I alluded to, the real-time dynamics between independents, chains, and as it pertains to the PBM. But I would just like to, if I may, we have ongoing contractual relationships with PBMs like we do with all other vendors associated with these service delivery lines. We try to manage that contract as best we can. If you do, the discrepancies you've mentioned are things that we've heard before, but I would just ask that we can reach out to you, CVS and our SHBP team. As do all our vendors, have a good collaborative relationship where they try to solve problems on a regular basis and address issues we're having at the local level, to hear them out and kind of assess what can be done. So we don't have our head in the sand. We know there's some frustrations out there that exist in this space, but also whether it be Medicare Advantage or anything else, it's our job to understand what the marketplace is looking like, what operations are looking like, Medicaid or anything else, what decisions we make here, how that's playing out downstream, if you will, to providers and patients. So we are cognizant of some of the dynamics, or I'd like to think all of the dynamics going on between the independents, chains, and pharmacy benefit managers. But that being said, we acknowledge that we do have contractual responsibilities. And so that's why we do have a ongoing dialogue with CVS, multiple touch points a day on just the delivery of services. So I'd ask you, Mr. Mobley, if we can, I'd love to kind of discuss how we can have a discussion between those pharmacies you reference and what they're seeing, and allow our SHBP team to take a deeper dive on what they're facing as it pertains to PBM, just like we would any service line,
Right. And I think-
SHBP or otherwise.
Right. And I think maybe something we should do is just simply say, whatever you pay yourself, you have to pay independents. And then that discussion is pretty much over. I mean, CVS is publicly traded. Our independent pharmacies are not. So when we give state health benefit dollars to these large corporations like that, obviously they're making a profit. You know, we've had 4 pharmacies that have shut down this year just in the state. I don't understand, you know, why we can't make these publicly traded entities that are taking our state health money when, you know, they're definitely making a profit. You know, they're not doing this out of goodness of their heart. They're not saying, you know, we're not going to make a profit. So even though they pay themselves sometimes thousands of percent, multiple thousands of percent more for a drug that they pay an independent pharmacy, they're still making a profit on top of that. So, you know, I just, you know, my biggest issue, and I've talked about this before, I think it's kind of rich that a pharmaceutical publicly traded chain is also the pharmacy benefit manager who has to divvy out that money to the independent pharmacies in the state. And you know, I'm a little bit more raw with this. I'm sure Dr. Coles is as well, but I can tell you just personally, this week I had that issue with CVS saying, and that we heard our patients saying that, but they personally said, yeah, you got to come back the next day. I mean, there's been a huge COVID outbreak in Georgia. I think we're all pretty much aware of that. It's okay saying, hey, you know, we're out of medication. We get that. We understand that. Not everyone can have that. But when they tell you to come back the next day, they just have so much business. Well, if they've got that much business and they can't handle it, then how about let's pay the independent pharmacies their just due amount of money, and then let's get it, because the profit that they're profiting off of that, if they would pay the independent pharmacies what they should be getting paid, then everybody wins. And I think we all agree, we want everyone in this state to win. But when they make that kind of profit off of our state health taxpayer dollars and state health benefit, that's going to line people's pockets that are far outside of the state. Our independent pharmacies, they're hiring people locally. They're trying to keep people employed locally. I mean, I've got pharmacy owners that, you know, are baking cookies to make and having side hustles to keep their pharmacies open. I've got a pharmacy owner that I know that has to moonlight at a local hospital commissioner just to make ends meet. And if they got paid a fair amount of money for these drugs, they wouldn't have to do that. I mean, do we really want a landscape to where, you know, basically all that's left, and obviously these large corporations and chains can't handle the volume. When they start telling you come back the next day, we might have it. And then, you know, you can call up a local pharmacy and you can say, hey, can you fill that for me? Well, yes, I can. Either A, I'm not contracted with the PBM to get it to you, or B, we don't fill it because we lose money on every prescription that we fill. So, you know, my goal here is not to be difficult or anything like that, but I do think that we have the power, we have the control in the state to tell these PBMs, if you want to contract with us, you've got to pay other people the same amount of money that you pay yourself, which is why I don't understand why, you know, CVS is actually also the same, is also the PBM. I think it's crazy, but I'll stop talking about that subject for now. But I think that we need to have a bigger discussion about this, because this is not going away. They're hammering us every day, these independent pharmacies. And I hope now that they're getting the, you know, the recognition that they deserve to get a fair shake and a fair chance to take care of people in Georgia. Because a lot of these independent pharmacies, they're taking care of the local community. When CVS, if you notice, Commissioner, when CVS doesn't make enough money in a local community anymore, they just shut down and walk away overnight. These independent pharmacies can't do that. They're part of the community. So my prayer and hope is that as we move forward, that we find a way to make them a larger part of what we're doing. Thank you so much.
Thank you, Mr. Mobley. And I appreciate that input from the field. Like I said, it's our job to not be comfortable here in our Atlanta office, and it's our job to kind of listen to all the dynamics, not just on PBM issues, but Medicaid issues, and in all aspects of what the department's responsible for. So I do appreciate that input, and I appreciate Lewis and his team always being mindful of what's going on nationwide across the field, and always keeping our members, at the end of the day, our members' best interests at heart. So thank you, Lewis and the whole team. Like so many parts of DCH and this applies to everyone that's presented today. There's not this team of 800 people doing all these things. So, so Lewis, not only to work on putting a responsible, plan together, doing the best you can from a financial perspective on rates that are responsible. But then, oh yeah, knowing that these are sensitive issues, you go out into the field on both the Medicare Advantage University side and your traditional annual circuit with just open enrollment. You take the conversation to retirees, to members, to teachers, and make sure they're aware. So all these things don't happen on accident. So it's a pretty small and nimble team, and please know how much we value all you do. So, thank you.
Other comments, questions from the board for Lewis, please?
It's David Cruz. I just had another question about the Medicare Advantage. Obviously, that's a pretty big change for those that have been with United. Are we expecting a good bit of shift of people moving from Medicare Advantage with United over to the other
Lewis,
plan?
did you hear
$20?
David's question?
Yeah,
I was
yeah,
having a
sure,
little
sure.
trouble hearing him.
No,
myself,
I
but
could
you go
clearly
ahead.
respond to that. I mean, obviously, based on the premiums that are there, as you say, there's a significant difference one between an $82 and a $60 premium. I think the good thing about it is that members will have a choice. If they want to stay with United, they can in fact do that. But we do anticipate there will be some shift. The most important thing about the plans is that there is no plan design changes. The plan designs are the same with both carriers. So there won't be any loss in terms of benefits, in terms of co-payments, in terms of requirements, but that we would anticipate some shift. But once again, it is, the members have that option to stay with United if that's their desire, and if they want to stay with Anthem and, pay the $20 increase that's going on the standard plan.
So just to be clear, you're saying that the Anthem plan is equal to the current United plan?
Yeah, they have the same benefit plan design. So there's no difference in the benefit plan designs. And let me add, our PPO, our Medicare Advantage plan is a PPO plan. And unlike some other Medicare Advantage plans, you have the ability to go in network and out of network. So that's the other difference. Some of the individual plans and some of these other Medicare Advantage plans, they are HMO plans, and it restricts the patient's ability to go outside of the network. And one of the things I think we've seen in cases where some of these payers have had contractual issues with some of these hospital systems, our Medicare Advantage folks have been able to continue to receive care. So the care hasn't terminated because that commercial contract terminated. So we are, anticipating obviously that, Anthem will continue to provide the level of service that has been provided, and United will continue to provide the level of service that they've provided.
Thank you.
Other questions, comments? Lewis, just so I understand the bottom line here in what we're saying, the plan structure is the same as it has in the past or last year. We
Yes, sir,
haven't
Chairman.
changed
Yes,
that.
yes, sir.
The increases in cost are overall, you say about 6. If I'm a participant, I'm asked the question, what benefits do I get here for the additional costs that I may be paying, which is in the area of about 6%. And that is being driven by cost increases. Is that correct?
Yes, sir. Yes, sir. Basically, it's medical cost increases that we've
Medical cost
seen.
increases. I think.
And from a national perspective, medical costs, depending on in terms of claim costs, it's, between 6 and 8%. So.
But there's also some coverages that I may, if that happens to pertain to me,
You will
like weight
continue,
loss drugs and things like this that are driving some cost that I have, that hasn't been there in the past.
yes, yes,
And
sir.
if you look at historically and having been here for a few years and seeing our health benefit plans, we've held costs pretty steady and even no increases in cost to participants in some of the years past. And I think you said if you take average over 10 years, it's about 1.4%.
Yes, sir.
That's that have actually have increased. The other thing I point out here at the bottom line, as I understand it, if I'm a participant and I'm looking at the enrollment, I have to enroll in one of the options, or you will automatically be enrolled in the lowest cost option.
Yes, sir.
Unlike some programs that I've seen personally in the past in the corporate side, if you didn't make a decision, you just went on with the same program you were on before. And so that's a distinction here that people need to understand in their enrollment, that they actually need to make a decision
Yeah.
on which plan they want.
Yes, sir. And let me explain. That's primarily driven to the fact that, we did a invitation for proposal. So based on that, we just couldn't, default people into plans. I mean, there's some CMS, Centers for Medical Services guidelines that you really just can default. So,
Okay.
but we do, as I've indicated, is that, our Medicare Advantage participants will have an option. So they will continue to have that option. So that option is not taken away. It's just there's what we call a safe proof to make sure that nobody loses coverage. And that's the most important thing, is that nobody loses coverage. Come January 1, that if there's a medical issue, that people will have coverage available for them.
Okay. Thank you, Louis. If there are no other questions or comments, is there a motion for approval for the, cover all or both resolutions in the plan? Is there a motion for approval?
Motion for approval, Cynthia Rucker.
Dr. Rucker has made the motion for approval. Is there a second? Is there a second to that? I'm sorry.
Second Williamson.
Yeah, Anthony Williams had seconded that. All in favor, say aye.
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 Opposed? Abstaining? Hearing none, it is approved, Louis. Thank you very much.
Thank you, Chairman, and thank you, the board, for your support.
With that, it concludes our agenda. Does anyone know of any new business or have any comments that they'd like to share at the closing?
Mr. Chairman, if it's appropriate, I failed to mention a couple calendar items, if I may briefly.
Oh, yeah, go ahead.
That's my fault. I do, and thank everyone for their hard work today, and thank members of the board for the discussion. On August 27th of this month, the Lieutenant Governor Jones, will be hosting his second Constituent Services Day here in this very room. I believe literally over a dozen agencies, state agencies will be represented for constituents from across the state can come and whether it be renew a driver's license or talk to someone about various Medicaid options that's available to you. So August the 27th here in this room, and more details on that. And also credit to Grant Thomas and a lot of our team and our DFACS counterparts hosting several programs across the state throughout August and September, promoting the governor's Pathways to Coverage program. We have over 35 events throughout August and September alone, to where we'll be informing citizens across the state about their options for this program and other Medicaid services. So we'll be posting deadlines on that. So I apologize failing to mention a few calendar items, and Lewis and his team will be our website will be hosting all the aforementioned Medicare Advantage University and open enrollment activities. So be on the lookout for a lot of different calendar items coming from the department. So thank you, Mr. Chairman.
Thank you, Commissioner. With that, if there's nothing else, I'll just remind us that we have a second board meeting this month, August 22nd, 10:30 a.m. And the primary subject will be the budget.
Yes, sir.
With that, the meeting is adjourned, and thank you so much for your time this morning, both for the listeners and the board participants. Thank you.
Thank you.